Thank you, Adam. And it's a pleasure to be here with this distinguished panel and audience. I'm an epidemiologist on the faculty of the Bloomberg School of Public Health in the Department of Epidemiology and International Health. I've had the privilege of living and working in rural Bangladesh for the past 10 years, setting up and running a large research site in the north of the country where our objective was to evaluate strategies to reduce infant and maternal mortality through simple, cost-effective interventions. So there was a slight conflict that USAID did support the bulk of that setup initial work, and we're really indebted to AID for making that critical investment, because this is now a window into the way typical Gangetic rural South Asia lives, breathes, and unfortunately dies. A window of opportunity to understand the complex ecosystems that lead to these mortality events that we often reduce to a simple statistic of cause of death. But when you focus out from that distal event and try to understand the complex pathway, the trajectory that women and infants undergo before they reach that endpoint, it's very important to give us insights into where we could intervene. We were speed talking with Adam just a few minutes ago about what our experiences were in the field, and earlier this afternoon I shared that we had the tragic privilege of observing over 1,000 deaths over the past 10 years in women of reproductive age. Roughly half of them were pregnancy-related, the other half were non-pregnancy related. But the common thread in these pregnancies was trajectories that led to mortality, and counterfactual to those deaths, we also had women who almost died. So in the maternal community, we refer to those as near misses. And by examining the trajectory that near-miss women undergo, you're able to identify disruptors in that pathway between crisis and the moment of mortality, to learn from what potentially we might use to scale up in a program context. One of the things we talk about when we talk about opportunities for mHealth is that in the most urgent sense of the word, how do you prevent the deaths that take place? Mobile phones offer us the ability to compress the time from crisis to care. And that's sort of a critical way that we were able to observe in a context where there was no existing mHealth program or infrastructure. In about half of those near-miss events, I think for 12,000 pregnancies over the past 3 years, we saw 600 near-miss events. 350 of those near misses used cell phones to disrupt that trajectory to mortality. Now, how did they use cell phones? For what purposes? Well, 3/4 of them used cell phones to call a provider to their home. That was the lion's share of what was being done. About 2/3 of them used the cell phone to secure money, to pay for downstream services. Because that's something that often gets lost when we talk about mHealth interventions. These don't exist in a vacuum, right? There's a complex ecosystem, there's downstream services that even if a woman is able to access a cell phone and access some information through that cell phone, then there's the downstream support systems that have to be in place. So one of the things we looked at was, how is cell phone ownership correlated with socioeconomic status? And over the past 5 years, we've seen a nice steady increase overall in this typical rural population of cell phone ownership, going from 20% to 47%. Now, when you stratify that by low and high socioeconomic status, the wealthy 20% of that population went from about 27% to 53% ownership. But the poorer 80% of that population, because even when you talk about rural poverty, there's a stratification of wealth even within that population. They went from 7% to 20%. So when you ask the question, where are these deaths taking place? It is in that tranche of the population, the poorer population who may not have access to cell phones to get those life-saving messages, to get that behavior-modifying intervention during the course of pregnancy. So those are sort of equity gaps that I think are important for us to address when we come up with program strategies. Now, on a positive note, we also looked at, within this trial context, one of our objectives was getting to the birth immediately after it took place. So for the past 6 years, we've been trying to get to birth to weigh the newborn for research outcomes. And we've been able to get to the birth within about 15 hours. Now, we looked at whether having a phone in the home had an influence on the time to get to that household. And in fact, it did not. Whether or not you had a phone in your household, 15 hours was the median time to reach that newborn to measure and weigh and assess for health status. So that means for crisis notification systems, neighborhood phone access or community phone access may work just as well as household phone access. But where it doesn't work is when you start talking about targeting the women during pregnancy to deliver health messages or to interact with them and build rapport on a one-to-one individual level. Now, I'll just finish with one other experience from Bangladesh. The other strategy that we piloted, because one of the research goals was to evaluate placental health. So to evaluate placental health, you need to get to the household shortly after the delivery takes place or even before the delivery takes place. So we set up an emergency obstetric nurse midwife target team, SWAT team if you will, right? So we trained them through the government curriculum. We wanted to do this in a way that we could assess whether this would be a sustainable, scalable strategy for our programs. So we had six or seven nurse midwives who we trained in EMNOC, and for the past 2 years they've been using a mobile phone notification system. When the woman goes into labor, her family calls our team, who is then dispatched to be there at the time of birth. This is hot off the presses from our field site in Gaibanda as of last night. So far, we've had 502 pregnancies. 430 of them survived to the 3rd trimester to alert us when they went into labor. Out of the 426, we got 387 calls. Okay? So 426, 387, someone in the audience can surely do the percentage math, but that's a pretty high coverage. Out of the 387 calls, we were able to attend 367 of those births in the home. So not in a facility, but actually dispatched as EMNOC nurses to the home. 83% of those births were assisted by the nurse midwife teams. So can we get to that window when we look at the Lancet series, where are the births and where are the deaths taking place, both for moms and newborns? It's right there in those first 24-hour perinatal window. The answer is yes, we can target the highest risk period of life. Off those 83% of the births, 30% of them were after the placenta had been delivered. So, roughly 70% of the births we were able to attend using this dispatch team. So strategies from research-based organizations can now inform and guide, I think, the program world in terms of strategies that work.
And I'll just add, for those of you who may not be aware, that skilled attendance at delivery is the intervention for preventing maternal as well as newborn mortality. So it's one of the critical interventions that we're striving for, either skilled attendance at delivery in the home or, better yet, in the facility. And so one of the challenges will be to actually get women in labor to a health facility at some point. And I'm sure that cell phones would help with that as well. But thanks very much.